In healthcare, thorough communication between providers is important for many reasons. One reason is to provide quality healthcare that is continuous, but also to prevent medical errors that may cause harm to the patient. Research states one of the leading causes of medical error is breakdown in communication. When working in the secondary school setting, the most common way I communicate with other providers, such as physicians and nurse practitioners, is by clearance notes. However, I have noticed that the diagnosis, right knee pain, doesn't truly give me any valuable information. From the lack of information included in clearance notes over the past year, I was able to create a note ranking criteria from 1 to 5, where 1 is the lowest score and a 5 is the highest, including all necessary patient information. Necessary information that needed to be addressed in a patient clearance note includes the diagnosis, the patient's clearance date, a care plan, any activity restrictions, and if a follow-up appointment is necessary or has been scheduled. If all of these criteria were present, the note would receive a score of a 5. However, not a single note during this entire process scored a 5. This quality improvement project's aim was to improve interprofessional communication across healthcare systems. During my needs analysis, I realized that majority of clearance notes were missing valuable patient information, to no surprise. This quality improvement project consisted of a needs analysis lasting 15 weeks, followed by 3 PDSA cycles lasting 4 weeks each. In the first cycle, my first intervention was a follow-up provider phone call to obtain any missing information from the clearance note and to provide the best possible care to the patient, which prevented any delays in care and would hopefully return the patient to play as safely and quickly as possible. The second cycle's intervention was referral sheets I created. For this intervention, during an initial evaluation with the patient, I would fill out the top half pertaining to the patient's injury or condition, and then the provider would fill out the bottom half, and the student would return to school following the doctor's appointment with a filled out sheet. My final cycle's intervention was a combination of the two. So during each cycle, my variables included the short form 12 with a physical and mental composite score, the clearance note ranking, which is from 1 to 5, the Press-Ganey patient experience questionnaire, the interprofessional collaboration scale, and communication frequency with the provider per week. Cycle 3 was a combination of both of these interventions and displayed the highest average clearance note ranking of a 3.6. All data was analyzed using t-tests to sample assuming unequal variance to determine significant differences between variables across all cycles at the 0.5 alpha level. A single factor ANOVA was run at the very end to compare average note rankings throughout all cycles, including the needs analysis, because this was the common variable measured. Unfortunately, there were no significant differences observed. However, during this process, I found the use of patient-reported outcome measures to be successful and detect change over time, but also to better understand patient experiences and obtain valuable patient information based on their physical and mental health. From these findings, these are 2 interventions other athletic trainers may adopt and execute in their clinical practice within similar organizations and secondary school settings, of course, to improve interprofessional collaboration. Thank you.